So once again, a very warm evening, good evening to all our participants across the globe, not just India. We have viewers from across various countries, and this is our third edition of Macular Hole, or the third webinar on Macular Hole, where we went from the basics to the conventional ILM peeling, and today we're going into the advanced territory. So we have a team of the Vitreous Table. We have the Dashing Divyansh, Curious Chitranjan, Serene Sharad, Smart Shishir, and our always happy evergreen and ever helpful Avnish with us. Apart from our the usual suspects, we have today two of our young and dynamic presenters, Dr. Chintan Desai and Vidhi Bajpai, who will be presenting their videos, and of course the magnificent Mohit, who has just joined in as well, and that beautiful smile. Great. So, and like last time round, where we had a wonderful commentary by Dr. Rajanarayanan, today we are honored to have Dr. Rupak Biswas with us, who will be sharing his experience on such complex macular holes with us. So, without wasting further time, let's go ahead. Last episode, we spoke about the conventional peel, the technique of ILM peeling. What are the traps which are there in ILM peeling for a beginner? So I want to bridge the previous session with today's session, and starting with Dr. Chitranjan. The question to you is very straightforward. That in your practice, what are the key indications for choosing an inverted ILM flap over a conventional one, especially in large or chronic macular holes?
Yes. Thanks, Mavik, for the question. So, inverted ILM flap technique we use traditionally in large macular holes. Large means it is traditionally defined by 400 micron minimum linear diameter. But sometimes our threshold for this 400 becomes 600. So, somewhere between 400 600. If it is more than that, we go for a ILM, inverted ILM peeling, and this is for the senile or idiopathic macular hole sampling. In addition to this, the other indications will be myopic macular holes and chronic macular holes. Chronic macular holes meaning we can add the indications like say retinal vein occlusion associated chronic macular hole, or say even sometimes diabetic retinopathy, advanced PDR case, sometimes we get macular holes. Other indications will be refractory or recurrent macular holes, traumatic macular holes with RD, post-opal RD if we get, or sometimes, if we extend the indication further, OD pit maculopathy kind of thing. So, basically, wherever the macular hole is not a simple small one, not like senile, like traditional 400, less than 400 or 500 or 600 kind of thing. In these cases, only in the simple cases, we can go away, escape with a traditional ILM peeling. But other cases, we have to go for a inverted ILM peeling. That is my practice.
Okay, I think some very good points you brought about Chitranjan about especially myopic holes. So I'll
Yeah.
come to the discussion once we start the video-based presentation. So our first video is by Dr. Vidhi. Vidhi is presenting with us for the first time. She's a VR surgeon at Nirmal Ashram Eye Institute in Rishikesh. I was privileged to be a colleague in Eli Prasad Eye Institute a few years back. Vidhi, over to you. I'm going to play your video. If you want to commentary, you want to give a commentary, it's up to you.
Thank you, Dr. Bhatik. Thank you for this opportunity. So this is a technique which I've been practicing for the last 1 year now. Began in the last 6 months of my fellowship and then has continued on as my consultancy as well. So the normal basic steps where you do core vitrectomy and then we induce PVD and complete the vitrectomy. After that, I stain. I preferably stain under here, and then I start from wherever which is the area which is most accessible to me and the one which is I feel is stained best, and I go around in a circumferential fashion, making multiple flaps. So this is the first flap that you see in the video that I'm raising. So I'll just take this flap till the edge of the macular hole and leave it there. I do not like to touch the macular hole in any fashion. So again, this technique was taught to me by Dr. Padmaja, who calls this the flower petal no touch technique. So she emphasizes the no touch part of it as well. So I don't touch it at all, and then we go around and complete these multiple flaps. So the size of the flaps, I try to start peeling at least one disc diameter away from the macula and try to make the flaps of around that uh, length at least. The width may be different, but we try to get at least four flaps or more. So more flaps would be thinner. So there is a little bit risk of them breaking when they get to the edge of the macula. So I do try to complete this in four flaps, but here I think I've made around five or six in this particular video. So then I do a complete fluid air exchange while staying at the nasal side of the disc. So as you can see in the video also, the flaps sort of lay across the macular hole when I'm doing this fluid air exchange. I'm not really bothered about positioning the flaps or touching the flaps at any matter. And I wait for 30 seconds and then do another round of fluid air exchange, and then I close under air. So this is the case at the whole achieve type 1 closure and the patient gain 20/40 vision. I would like to thank Dr. Padmaja for teaching this technique to me.
Right. Wonderful video. Vidhi, you are a left-handed surgeon or the video was inverted?
The video was inverted. I'm a right-handed
Okay.
surgeon.
Like, I think there are different challenges for a left-handed surgeon. I'm not sure of that. Yeah. So great then. Yes. So with this, I want to bring in Dr. Divyansh and Dr. Chitranjan here for the next set of question. So Dr. Divyansh, okay, we'll do one thing. So what was shown here is a multi-layered flap. Okay. I just received a video from Dr. Shishir who has done a large temporal flap. So let's look at it and then we'll compare whether which is better. Okay, are there pros and cons of a large multi-layer flap versus a large single flap? Can you see my screen?
Yeah,
Yes,
visible.
Ravi. Yes.
Yes.
So can I talk on it, Bhavik?
Yes,
While
of course, of course. I'm
yeah.
going to play now. Yeah.
Yeah, so this was a 68-year-old male. You can see how flat the little bit of the macular hole is, large hole. So I did a 27 gauge vitrectomy over here. So here you have to be careful, especially you need to clear the infusion first, and then I usually do the temporal flap technique. Now the issue with this small 27 gauge forceps is there are pros and cons to it. The pros is that the iatrogenic trauma if you're creating is slightly lesser. So here I peel off the temporal ILM. You have to do multiple regrafts because the surface area of the forceps is relatively little lesser as compared to the 25 gauge. So after I peel off the temporal ILM, I completely peel off the nasal ILM because my theory is that you require a temporal ILM to cover the hole, and then you peel off the nasal ILM to remove even the traction from the nasal region. So I completely peel off the nasal ILM there, making sure that I leave this, temporal part. And you can see it's a large temporal graft. So the why I do this temporal graft is like when you're doing your fluid air exchange towards the end of surgery, the graft you can see automatically comes all over the hole and then just lies over the hole. And this quick fluid air exchange followed by an SF6 injection. And then when the patient comes 2 weeks post-operatively, you can see the hole closure. And that's the video also showing the closure of the hole with improvement in vision.
Great. So two different techniques, and one important point was Vidhi, you just put air, right? You did not use the gas. Whereas
No.
Shishir also used an SF6. So Dr. Divyansh, what do you think is a better stability or a higher chance of hole closure comparing multi-layered versus just a large temporal flap which is just turning upon itself? We'll discuss about the air and the gas later on, but we'll first go with this technique part.
See, I would say the kind of hole which we are looking at, I think peel, no peel, peel, only temporal peel, peel,
Dr.
like
Divyansh, can you be a
quantity.
little louder? I am not sure if others also feel the same.
Okay, you are able to hear me now?
Yeah, little
Hello?
better, but if still you can just speak a little louder.
Okay, so the question is which is better? I would say whichever it works in that surgeon's perspective because somebody has learned that okay, making like a cabbage or a flower petal kind of inverse flap works, or some people do it like complete, means not like how it has been suggested that you peel completely till the macular hole. So you do like a small bit by bit and then keep the central donut and then peel it at the end. So there are multiple ways to manage the same thing. So which works the best, I'm not sure, because there is no like a comparative study to say so. It's just whichever works better in their each hand. So, and tamponade wise, as the discussion has already occurred, we can take it forward. But I'm not sure really that which is better than which. So
Yeah.
anything which works better in their hand.
So basically, in both the techniques, we're not shoving the ILM into the hole, right? Just to be clear.
So the answer is, if we are trying to shove the ILM into the hole, then we are creating damage at the subfoveal RP layer,
Yeah.
and that would cause the outer layer loss, and that's going to cause the further decreased vision or no improvement in vision. So one caveat which I wanted to suggest to both the surgeons was not to have a larger flap. Why? I am not sure whether you guys have seen post macular hole ERM formation. Why? Because in Vridhi's case, if we can see, there is a negative staining in one of the areas. I think depending upon, because it was, the video was inverted, there was one area of a negative stain. So if we follow up such cases post-operatively, 1 month, 2 months, 3 months, we may see that there may be a pucker formation because the ERM part has not completely been managed. So how we can manage it is either by having a smaller flap. What we understood in the cases where we had post macular hole closure ERM formations, like in a larger flaps, were having a larger flap of more than half this diameter, is what we could understand. So that was a basic culprit. But otherwise, yeah, fantastically done surgeries by both of them.
Yes. Thank you, Dr. Divansh. Dr. Rupak, you want to comment on this particular technique?
Yeah, I think I will echo with what Divansh was telling. See, this is the most importantly is that you need to cover the macular hole. So it has been proved that larger size of the macular hole, for larger size Western world, they take it as a 400, more than 400 is a large macular hole. But for us, probably 600 or more we do take. But anything beyond 400 or 600, we should plan for the inverse flap. Now, this inverse flap have a different technique, like both of them have shown in different way. Yeah, definitely, if you can cover this macular hole, that acts as a scaffold for the hole to get closed. Now I'll completely agree with Shishir what he has done. There are few surgeons another school of thought that the temporal flap they just put over the macular hole and the nasal part has completely untouched. So I will not agree with that personally. Because of the reason, because of that, then you have a differential traction of the ILM. So in that, the nasal part is still having the tractional component is there, and the residual part, the temporal part has been released. So that can cause some amount of the macular hole. Depending upon the macular hole size, again, it can close even if you put the half of that. Regarding gas or air, yes, both of them are almost equally effective. Because initial 3 days is what you 2 to 3 days is the maximum time what is you need to get prone positioning for that.
Thank you, Dr. Rupak, for the concise answer. Since before moving on to the further considerations about using PFCL or Visco, staying on to flaps, I have one more question. A very important point, interesting point what Dr. Chitranjan mentioned about in macular, in myopic holes. So this question is Dr. Divyansh and Dr. Chitranjan both. In myopic holes, do you wait for 400 microns or even the smaller holes you want to close with the flap?
Babik, if I can take this question, more than the whole size, it is the symptom of the patient that drives the surgery. If there is recent drop in vision and we see there is a, we are following the patient and there is a macular hole.
Agreed. So we are considering all of this. The patient is symptomatic and needs surgery. Yes.
Yeah. So if there is a hole,
part of it, yeah.
Yeah. So if there is a hole, then we have to go for surgery. And ILM, yeah.
ILM flap, you mean to say? Okay.
Yes.
So in cases of MMT, means a myopic macular traction associated holes, it's the traction which has to be managed and not the size of the hole.
Okay.
The problem is if we are waiting for the hole size to increase, the vision has already been lost at that point. So the visual improvement is not expected. So obviously, as Dr. Chitranjan was also suggesting, that if there is a proven documented evidence of decreased vision and a documented evidence of worsening of an MMT, ideal would be to manage at the earliest.
No, I agree. My question is regarding the technique of ILM flap. Do you have a lower threshold for a ILM flap in myopic macular holes? Being very
Oh,
specific.
Acha, the question is for myopic macular holes
Yes.
having
And
inverse flap or not.
yes.
Yeah. So if it's a smaller hole, I do not want to have it. But if the hole is around 400 microns to 600 microns, then only I would think of having an inverse flap.
Wonderful. Okay. Great. So, fine then.
Dr. Bhavik, I just wanted to add one more point with this regarding myopic macular traction. So if it is associated with hole, probably I will do a larger size of the peeling. Even if it is associated with the inverse flap also, beyond that, I will try to release the ILM peeling as much as possible.
Great. I would like the audience to have suggestions or what they do in the commentary on YouTube or on Zoom link here about what are their thoughts on flaps, usage of flaps for closure of macular hole. And with this, we move on to the next segment, which is a chapter 2 about usage of various techniques in terms of visco-assisted, PFCL-assisted. And once again, we start with a video, and this is by a very own Dr. Avnish, where he's performed a visco-assisted macular hole closure. So I'll just sharing the video.
So,
Okay, over to you, Dr. Avnish.
yeah. Can you, lower the voice, please? Yes, thank you. So basically, now we have had like inverted flaps, which has been discussed. So I'm just taking it a bit up with stabilizing these flaps. Sometimes the flaps can get dislodged, and sometimes, the flaps, what Dr. Divyansh was talking about, epiretinal membranes. So here we actually stain the posterior pole with BBG dye, and then we start with the peeling, and I usually do it in the intertemporal arcade, use the pinch and peel technique, and that is almost 1 disc diameter away from the fovea. And then once those multi-layered, I prefer multi-layered flaps. And I tend to make around 4 to 5 flaps, as what Dr. Vidhi was talking about. And then I complete doing the peripheral ILM arcade, up to arcade peeling is done. Here, what I tend to do is I trim the ILM flaps which is there. What I would advise is one should use newer cutters. The What I do is, like, I do use very low vacuum, say 50 to 100, and high cut rate, so that the trimming can be possible and it is not sucked into the cutter. Second thing here, once those flaps are made, then I use viscoelastic here, and I try to place it over the surface of the fovea and then try to slowly scaffold it. The other thing which I have actually changed is, like, I don't peel up to the edge of the hole. I leave like around 100 microns of a hinge of the ILM uh, till towards the edge, so that the graft is not dislodged. And then after that, I do the FAX, and then after FAX, I use SF6 as a tamponade and positioning for a week. So another case is there after this. So one more thing which I wanted to emphasize was I have actually shifted from using flute for aspiration to cutters in these sort of multi-flap techniques, where I tend to face the cutter away from the fovea, so that will actually help in not dislodging the graft, and that can also help in scaffolding as well as stabilizing the graft over the hole. So this is my second video, and it is on similar way, which I'm doing. I'm peeling and then removing the remaining ILM till the arcade, and then I use viscoelastic. Viscoelastic can be used using soft tip, and in the first case, I actually use a 26 gauge long needle which was cut at the edge. So with that also, you can slowly inject the viscoelastic over the fovea. I do tend to decrease the intraocular pressure and bring the IOP to 25, so that the pressure don't go up. You can maneuver using the ILM forceps or the cutter so that can be the scaffold is nicely placed, and then you can stabilize this with a PFCL.
In your case.
You can see we can using a folded ILM forceps, and that is actually being used to stabilize as well as close the hole. And then again, you can see the cutter which has been used. So once that FX is complete, you can slowly see the draft is not getting dislodged, and I use a tamponade, and then I use positioning in these patients. Thank you, Dr. Bhatt. So this is 1 month. The previous case had a 3-month follow-up. So even then, I think we can discuss further on this. Thank you.
Yeah. Thank you, Dr. Avnish, for that wonderful video and the technique as well. Before we proceed to a discussion on visco-assisted, we'll go ahead with the PFCL-assisted video. Yeah, and for that, I welcome Dr. Chintan. So Dr. Chintan is a medical director at Rahi Netradam in from Dehradun. And Dr. Chintan is going to speak about PFCL-assisted macular hole closure. I'll request Dr. Chintan to be concise about. Yeah.
I'll skip most of the slides as much as I can. The reason why this needs a PPT is also because there's a study attached to it.
I understand. Yeah.
And but I'll try to be as quick as possible. So, how do I change the slides from here? No, you can skip these. You can skip these slides. Yeah, further.
You want to present it? It'll be better, I guess, since you're 21st.
Yeah, okay. So I'll do that. I'll do that quickly. So, 1 second.
Yeah. So by then, Dr. Chintan shares his presentation. Dr. Mohit, your thoughts on a visco-assisted ILM flap closure?
Yeah, I think that the technique showed by Avnish was great. I think one must sound, but a word of caution though. I think to my mind, the only role of putting viscoelastic after you fashion the flaps and either put them over the hole, or as Avnish did in the second case, he chose to put it in actually. He actually almost tucked it in, which is something that I wouldn't do. And part of that was spoken by Divyansh as well. Is that you're scared that during fluid air exchange, those those petalloid things might come off. Now, apart from that, I don't think viscoelastic per se has too much of a role. I can elaborate a bit more on that. I think after Dr. Desai is done, then maybe we can try and talk about both.
Sure. Please go ahead, Dr. Chintan.
Yeah. So I'll be speaking on PFCL-assisted macular hole closures. So conventionally, we had macular hole closures with the conventional.
So, Dr. Chintan, just to intervene, I think it's not in the slideshow mode.
Can you just play that thing if it's there right up?
Yeah, but I'm trying to find it.
No, just right up above. There is an option of play. Yeah, on the left side up. Play and keynote live. Yeah, add slide followed by.
Where?
Yeah, upstairs. Yeah.
This is slide control.
Yeah. Right on the left side. Yeah. Play. Left side. Extreme left.
Scroll your mouse to the left.
Yeah. Correct. Yeah.
So large macular holes used to be a problem with conventional ILM peelings and cause high failure rates. So newer techniques did come into vogue, and inverse ILM flaps, we started using them. But and it had a very good success. It still has a very good success. But there are two problems with the inverse ILM flap technique. One is while trimming the flap, like Dr. Avnish said, that while trimming the flap, we might lose the flap if the cutter is old, if the vacuum is a little too high. And secondly, while doing fluid air exchange, again, the flap might get sucked into the cannula, and this might cause flap displacements. Also, post-operatively, if there is a little bit of a cuff of fluid which is present around the flap, then in spite of the good fluid air exchange and SF6 gas, the flap might not be in its position the next post-op day. So visco devices have been used, but the problem with visco devices is that it tends to float and mix into the along with the fluid in the vitreous cavity rather than really stay on the flap. So taking these things into consideration, okay, so this is a video where I'm showing how the flap got sucked into the cutter while trying to trim it. So how did PFCL come into the picture? So I came across a study in IGO where they used PFCL to peel flaps, not PFCL per se to keep on the flap. But when PFCL was used, they noticed something, that the consistency of the flaps after coming in contact with the PFCL changed a lot. The flaps became more pliable, they became sticky. As you can see here, the consistency became very sticky and it was much easier to maneuver, and it stayed in its place in spite of FAX and everything that you do later. So this is the technique which we follow, which we've been following since 2020 actually now. So this is a patient with a large macular hole, 557 microns, not a very large hole, but 557 microns. Yeah. So I make multiple inverted ILM flaps. I've started with the nasal quadrant here, but usually I prefer starting with the temporal quadrant. And gradually I've also moved to temporal flaps now, where I remove the nasal ILM to remove the traction, but I make a flap only with the temporal part of the ILM. So after making these multiple flaps, I try to make smaller flaps now because I don't trim them anymore. So the size of the flap is not very large, and the remainder of the ILM is removed. Now I inject the PFCL, not before. I'm not peeling the ILM under PFCL, but I'm just injecting the PFCL bubble and keeping in contact with the flap for probably 30 seconds or so. Now see how the flap is behaving. Look at the consistency of the flap. It has completely changed. It is almost like a clump. You don't need to push the flap inside. You can just place it over the hole and it will have that stuck on appearance. This is followed by FAX, and sometimes I use gas, sometimes I don't, and this is the result of the patient after 1 month. So based on this, we also did a retrospective study of 57 eyes where 36 were operated with this technique, 21 with conventional inverse ILM flaps. And as you can see here, all the criteria are matching, and we assess the anatomical closure, type of closure, and if there was any remnant gliosis which was caused because of the PFCL. So these are the types of closures that we found, and as you can see here, the group B, which is the PFCL group, all 36 out of 36 holes between 2020 to 2023, they closed. We had a 100% closure rate, no flap related complications, and the type of closure and gliosis in both the groups were comparable, showing that PFCL did not really cause any significant gliosis. Like I said, there were no flap related complications. Comparing it to the original study where PFCL was used for peeling, they also had a 100% closure rate compared to 93% in the other group. And this is the current data which has been extended up to 26. So till now we've operated 147 eyes with this technique, and all of them have closed, and the gliotic changes or anything has not been significant. So the pros of this technique is that the ILM becomes very sticky, it is easy to maneuver, and there is no fluid cuff at the edge of the hole which might displace the flap later. So this gives us predictability, 100% closure rate for medium to large macular holes. The largest now that we've operated is close to 1600 microns, and there have been no complications which have been noted, and the BCVA, which I have not included in this studies, but the BCVA in both the groups has also been comparable. So why do this? Because you get a good night's sleep. You are not worried about the flap getting lost. We're not worried about the hole not closing, and hence we feel that this is a good technique. In fact, now I have around 3 or 4 more people who've started using this technique since the past 2 to 3 years, and friends and colleagues of mine, and all of them together they've done around 76 or 78 surgeries, and all of them have reported a 100% closure rate with good type 1 closures in any size of macular holes. So this technique does not give you anything extra in terms of the type of closure, but the predictability of the hole closing is much higher compared to using visco devices or using just inverted ILM flaps. Thank you.
Right. Thank you so much, Dr. Desai, for the technique, and I'm happy that you could convert this into a study. And I'm sure, I don't know if it's published or not. If not, please do publish it. And yes, we come back to Dr. Mohit about uh, the difference in the techniques and what provides better stability to the flaps. What are your thoughts on PFCL assisted versus a visco assisted technique?
Yeah, thanks, Bhavik, and great study, Dr. Chintan. I have two critiques of this, which I'll come to, at the back end of my comment. But I will. I have to say that I think one has to differentiate and dissociate these, two things. If one wants to take advantage of a liquid, which in this case is PFCL and not viscoelastic, to try and help in forming the flaps also, in fashioning your flaps also, then PFCL is the only choice. You can't put visco just after staining and then try and whatever be the case and try and fashion flaps. So if your retina is detached and you have a Mac hole, I think PFCL takes the cake, that way. If not, if you just want to fashion your flaps, I think fair enough, both things are similar. If the idea is, which I'm guessing what Avinish and Chintan showed differently, that after you've fashioned your multi-layered flaps and you've actually put them on, and you want to ensure that those flaps don't dislodge at the time of FAF, if that is the sole aim, uh, whether you want to put on viscoelastic or you want to put on PFCL, things are similar with two differences. And I'd like to point out to the second video that Avani showed and the video that Dr. Chintan also showed, and why I would give a big shout out to the initial video by Dr. Bajpai, and I think that is the way to go. And she said it very well, and Divyansh also mentioned this briefly in his comment after that. You want to be as less you want to stay away as much as possible after you fashion those flaps. You don't want to be trying to even fashion or even seem to be nudging them into the hole. And once you have either PFC or visco there, it kind of it kind of entices you to try and come and get actually close to it. So I would strongly suggest whether you use visco or PFCL as a temporary stabilizing agent, just so that during FAX it doesn't go off. Fair enough. Both are similar. But in both those cases, I would strongly urge and ask people to refrain from that tendency to try and get it, and because that is almost like stuffing it in. And you might say it's not, but it is, because that's the only way you actually get that into the hole. So stay away from that is what I would say. And my only critique of that excellent large work that you did, Dr. Desai, was the comment that you made at the end that PFCL assisted closure and ILM flap helps to close all holes of all sizes. If that were true, we'd have a one-stop solution for everything. So I don't think it works for all holes, all sizes, all the time. Despite the 100% success rate, it's a great adjunct. It is not going to work 100% of the time for holes. If you were to do a subgroup analysis from 600 to 1200 microns, the largest I believe you showed was 1100 something, you'd actually see that the success rate might not be 100%, would be my take on that. But great work, lots of patience.
Yeah, I was wondering the same thing, that if someone wants to learn retina macular surgery, one should go to Dehradun with 147 eyes and all. So okay, I'm going to play the devil's advocate here, to be very honest. If we're talking about large macular holes, Dr. Vajpayee and Shishir showed fantastic technique with the flap, right? Is there a need for an additional technique like a viscoelastic or a PFCL in larger macular holes? This is to Dr. Shishir, Dr. Chitranjan, Dr. Mohit, and Dr. Divyansh. Yes or no, or maybe just a single one-line comment. What do you think?
No. If you're doing so one line answer, if your technique is multi-layered petaloid thing, and if you're scared with the trimming and this, that, and the other, so if you want to try and you not hold the ear like that and go like that and do multi-layered flap, then I understand the hankering and the need
One line.
to try and visco.
One line.
But if you're Shishir and if you're doing Shishir's technique, then no.
Okay. Divyansh?
So I would give one caveat and then I would answer. So the kind of viscoelastic what you use is also important, because one of the cases in our scenario had developed a very severe posterior segment inflammation. So I don't want to label any viscoelastic which is like forbidden, but you can have severe inflammation. And if you want to try to keep a flap in place, then the best way would be to inject when you have already done a fluid exchange and not under fluid, because under fluid it's going to wash away. So my answer for both would be no, unless there is a detachment. So if there is a posterior pole detachment, then I would use PFCL to stabilize the posterior pole and stabilize the flap. But otherwise, for both of that, unfortunately, I would not agree.
Yeah. So just before Chitranjan or Shishir come in, and Dr. Rupak, I'll like to reserve your comment towards the end for this part. Uh, I want to emphasize that we are not here to criticize or to belittle any technique. We are trying to give you a practical scenario since we have so many listeners. We have, I was looking at the list, we have seniors as well as quite fellows who are just starting their macular surgeries. They should get an overall idea. It's just because a paper is published which says 99% closure, 95% closure, and 300 microns, they're using PFCL, and you should not feel that you're missing out. Okay, that is we want to give a practical approach of what exactly is required and what would work best in your hands. So Shishir and Chitranjan, quickly before we move on to the further.
For primary surgery, I won't use PFCL. For a resurgery macular hole, where I want to get an ILM flap for somewhere else and put on the hole, I would use PFCL. And macular hole with retinal detachment, that's the only place where I'll use PFCL. I'm pretty happy with the temporal flap technique. It's working quite well in my hands.
Yeah.
Yeah, Bhavik, I agree with Cecil and Dibans that primary surgery, PFCL, not in all cases, but as they have already told, myopic with RD is there posterior pole or it is a repeat surgery. But only in one case, my threshold for using PFCL will be low. That is a large macular. Large meaning I'm not telling 600, something like say 800 or something like that. More than that, I am little afraid of losing a flap over there, even though I'm doing a cabbage or flower pattern. At that time, my threshold for using a PFCL will be a little low. And if I have less experience, I am pro PFCL kind of thing.
Okay.
And just one change to what Dr. Chintan has told, what I do, like before putting PFCL, he has already stained the ILM and did the ILM, peeling. But we have been doing PFCL first, then under PFCL staining and peeling the ILM. That will be against what Mohit and Divans told, that we are stuffing it inside. I'm not telling manually going there and manipulating over there, but that gives one advantage of not missing even a single flap of ILM. But again, that comes at a cost of the bits and pieces of ILM, not a big ILM you will get. And particularly in chronic holes, and if we extend the indication from senile holes to diabetic cases, PDR with macular hole or chronic CM with macular hole, those cases the retina is really buggy. In those cases, holding the ILM and doing under PFCL really helps. Yeah.
Okay. Great. So
Can I just offer my 2 cents
yeah, please.
on the discussion?
Yes, please.
So I understand and respect all the views, and I understand where you all are coming from, and I understand why you feel that there is no need. I agree that probably 95% or 98% of these holes would close without using PFCL. And so this technique, like I said, it's not offering anything extra in terms of it's the results or the outcome. But what it does is it does three things. One, it offers you, like a lot of videos that you saw till now, the flaps were a little larger, and most of the times these flaps, when you make such large flaps and you don't trim them and then you put them over the hole, then most of the times you would see for months probably the ILM would be there over the hole even after the closure. Second, if you don't if you tend to trim those flaps instead of keeping them large, then there is a chance of flap displacement. Third, you do everything correctly, and sometimes especially in institutes where it is not always possible to use fresh cutters and fresh sclerotomies and fresh trocars and cannulas, there is a little bit of leakage, there is a little bit of seepage which happens, and there are times when post-operatively we notice that in spite of doing an FAX and injecting SF6, there is a little bit of fluid which keeps dripping near the flap, and it tends to displace the flap, and the next day you would observe that the flap is there but it is not covering the hole. So this technique, what it does, it nullifies all these components. And I agree that 600 700 microns would probably not require this, but we've operated on 1500 and 1600 microns. We've operated on traumatic macular holes which have been more than 1000 microns. We've operated on holes with retinal vein occlusions, with retinal detachments,
I think
with holes more than 1000 microns, and all of them have closed
no,
with
I
this technique.
Chintan,
So
Chintan,
that is
the point here is not about that. We are not going into the technical aspect of why this is closing or not. The idea of we discussing this is that the message should not be that this is the only technique.
no, no, absolutely not, absolutely
There
not.
is nothing
That's
wrong with your technique. You can do it for 300 microns, 15 microns. That's perfectly fine. The point is that a person who is just starting to do a surgery should not feel that, oh, I don't have PFCL, will my hole close or not?
No, no,
Right?
that's not what I'm
That is
trying to
that.
say. But yeah, for large holes and for complicated holes,
100%,
this
yes.
technique would definitely work and
Correct. So,
would
So,
it
Bhavik, just
has a
to
higher predictability compared to not using it for large holes and for complicated holes.
yes.
so
So,
Bhavik, just to interject and probably calm down the whole nerve. So, if you would have attended our previous sessions, I think I am the person who would suggest using PFCL for macular holes as a short-term tamponade. So we have used it, we have published
Yes.
also. So these are very specific cases where we have used. So you have used temporarily for that surgery, but we have kept it for 1 week, 10 days, and then we
exactly.
have removed it for macular hole where patients cannot maintain position and very hefty patients, neck issues, back issues. So don't feel otherwise, Dr. Chintan, fantastic surgery. It's just contradicting kind of what to say experiences. So don't worry,
No,
you have
I
presented very
respect
well
that, but
here, and
yeah,
surgeries
I'm
were
not.
fantastic.
Yeah.
No
So,
worries.
but
Don't
I'm
worry.
happy Dr.
Yeah.
Chintan ended on note on larger macular holes. So we come to the next chapter, the final chapter about larger chronic macular holes, where the hole on OCT is stuck to the underneath and the neurosensory retina is stuck to the RP underneath. So what do we do with them? So for that, let us begin with the first video about using the amniotic membrane graft. Again, we have Dr. Avnish for that.
Dr. Bhavi, can you just lower down the volume, please? Yeah. So again, yeah. So this is basically a case of a failed macular hole following a prior RD surgery, which had an ILM macular hole. We peeled it off, but the hole did not close. And this is after SOR. You can see this is the hole is very large. And here we have tried to use an AMG. And AMG is actually fashioned in a way where at least 100 to 200 microns, it is larger. This is what I prefer. Some people use it to the same size, but what I understand is over years, the AMG kind of contracts. So what we tend to do here is we use the ILM and we try to push it over the macula, and then we inject the PFCL and try to bring the AMG within the bubble of PFCL. And here we try to open it up. And then once that is done, under the PFCL, we slowly try to hold the edge of the AMG and try to push it over the macular hole here. Second thing which I want to emphasize is like when you're doing the PFCL, like when you're doing the FX, first try to remove all the fluid, then go to the PFCL, and after that you can see the hole, the graft is nicely placed over the hole, and this gives a good. Uh, can you just press? Can you just present? You can see the post-op photos if you can, Dr. Bhavik. If you can show the next slide and the results. Yeah. So you can see the graft is nicely placed, and this patient, this is the OCT fundus photo. There's an OCT also, Dr. Bhavik. After this, if you can press, yeah. So you can see the hole is nicely closed. So this will actually, this in these sort of scenarios, sometimes you can have re-RDs in these situations where sometimes these sort of tamponades will help in preventing re-RDs. And AMG has shown over the period of 3 to 6 months to improve the visual acuity in these sort of patients. So this is from my side.
So great, wonderful again, wonderful surgery. And before we jump into dissect Dr. Avnish's surgery again, so I'm going to go ahead and show you one more surgery, which is a counter technique, I'll say. Yeah. And here I would like to hear Dr. Rupak's thoughts as well on this.
Yeah. Can you forward a little bit, Dr. Bhavik? Again? Yeah, so this was a 74-year-old who's already undergone, macular hole surgery, and even after the first surgery, there was still a persistent hole. So in this patient, again the issue was the prone positioning and things like that. So I straight away decided to go and do a retinal autograft. It's quite a large hole also, and there was no ILM remaining within the arcades for me to kind of do a free ILM graft. And I don't have access to amniotic membrane like how Dr. Avnish has. I only have the dried amniotic membrane. So here I'm using a pick to fashion an autograft after endolasering the donor site. I use a pick to kind of fashion the autograft after cauterizing the retina there so it doesn't bleed. So deep cautery burns, and then I use a pick to fashion the graft. The graft should ideally be 500 microns larger than the size of your hole. And then after putting PFCL under the PFCL, I drag the graft. So if you have to drag it all along the retina. If you don't, if you lift it up and put it, then it tends to crumple, and then you have to kind of flatten it under the PFCL. So once I put it over the hole, and I identify it by the presence of the cautery marks which are on the surface. And then after putting PFCL, I exchange with silicone oil. And I don't know how, but this patient improved to 624 vision. Her pre-op was counting fingers 3 meters, and post silicone oil removal, she was maintaining 624 vision. And this is the post-op OCT under oil. And there's also one OCT which is after the silicone oil removal. I think Dr. Bhavik has that. Yeah, so that's she improved to 624.
I think Shishir, you have transplanted the photoreceptors also, so that is that to gain the vision.
Yeah, so the more
But
Bhavik,
posterior
that
you are,
that
the
that
more
is
chance of photoreceptor density being,
of course, of
yeah,
course.
that is one of the proposed hypotheses.
I know.
Once I was going to that podcast by Dr. Jayant, the author's name I'm forgetting, but what you told correctly, they were telling probably some transformation of the photoreceptor layer is happening. That is
happening.
too much of optimism, but yes, we have seen this is very good result.
The rods are converted into cones now, so
Yeah.
no, it's possible, right? Yeah. No, but I think apart from that, jokes apart, fantastic technique from both of them, Avnish and Shishir. So this is now open to all our panelists. We'll start with Dr. Rupak first. So what are your thoughts per se on retinal transplant or using AMG for such chronic holes? And how do you deal with them?
Uh, Bhavik, when there is no specific technique, there is multiple techniques. So we need to accept that. So all the techniques can close hole. Now the most important is that are we looking for only the hole closure, or we are looking for the functional ability of that area? So this is the most important part of it. Now, when you have a chronic hole or a failed hole, so these are the holes are usually larger in size. And most of the time you have a gap, which is usually a tissue deficiency. Now, if you have a technique where you can still, pull them closer and make the hole closed, then it is the best way of doing it. If it is not there, then probably the autologous retinal graft is the best way out as of now today. The reason behind it, whatever material you put it there, either it is a free ILM flap or a amniotic membrane or a lens capsule, everything is non-retinal tissue. So technically it cannot generate a retina in that area. Definitely the scotoma size can reduce due to the whole technical hole closure. Now question comes whether autologous retina graft, whether the amount of the photoreceptor, whether it is functional or good enough, or when you are pulling them to put it there, whether there is some amount of the damage to the photoreceptor. Yes, there can be, but again, still it is a retinal tissue which can have an aberrant regeneration between the cut end. So that is the difference between the technique what Dr. Shishir has shown and my technique is there where Dr. Shishir has done the cauterization of the surrounding area to prevent the retinal bleeding and then put it there. So if you cauterize the neural tissue, then definitely that neural tissue is completely damaged in that area. So there, the chance of aberrant regeneration between those two are less. This concept I am doing it for more than a decade with retinal trephine. The technique, the concept, what is there is from the aberrant regeneration where infraorbital nerve has been replaced with the sural nerve. And it has been seen that the infraorbital part, if you replace with the sural nerve, this part sensation in an orbital fracture, this part of the sensation has regenerated. So this is the concept that even if you see in case of, when you have a cut end of the hand, so the concept of general surgery has been applied here. So you see around 15 to 20% of the larger size of the graft, which you trephine there and then put it directly over there. You just peel it and put it there. And that's all. And here during that trephination process, the crushing effect does not cause that much amount of the bleeding. In my trephine, there is a catch which is there around in 350 micron beyond that. So even if you try to push it to the choroid, it will not go into the choroid level. So it has one is outer rim, which is a cutting rim. The other one is a stop, which will stop you to go to the deeper to the choroid level, so that the inadvertent injury to the choroid will not happen.
Yeah, I think it will be good if you could show us the technique in your presentation, Dr. Rupak.
I'm trying to do it, but my laptop is not getting connected. I think from the back end, if somebody can help me out, and then I will definitely show you. Regarding the flap of whatever is the previous description was there. See, there was a argument whether this PFCL will help is not. I think what Dr. Chintan has showed is a good technique. It can help. Now let me explain what is exactly happening there. So once you put a PFCL there, it acts as it is like a stamp kind of thing. You have did you have sometimes, if you don't have a press, then you fold your shirt and put it under the bed, it will be like a flattened. So once you put it under the different flap, if you put a PFCL over there, it will have a pressure effect on that. Due to that, it will definitely again will tend to fold it in that position itself. Okay, and if you don't switch on the fluid, and if you do a fluid air exchange from there itself and then take out the PFCL, then probably you will not have the flap will remain at that place itself. Regarding the viscoelastic, yes, you can have the similar effect of viscoelastic, but you cannot use the viscoelastic during the fluid itself. So you have the flap, do a fluid air exchange, fashion the flap, and then put one drop of viscoelastic just over it to make it stabilized. Third point is that try to avoid the larger size of the flap. The larger the size of the flap, it will have a more tendency to, again unfolding it more. There was one more important point which you all have noticed or not. Dr. Vidhi has mentioned is in the initial phase that she does a second round of fluid air exchange after waiting for 30 seconds or 1 minute. That gives whatever the fluid which is remaining over the wall, that comes down over the posterior pole. And if you take out that fluid, the chance of unfolding of those flap is much less. So this is a good technique, and this I do follow it for quite long time. It has a very good effect on that for the stabilization of the flap. Now, regarding whether you have a temporal flap or multiple flap or a cabbage flap, even if you have a little larger size of the flap, it will have, if you have there are two surfaces of your flap. The lower surface is having a more roughening, and that causes a much more, adhesion between those two. So if you have a cabbage kind of flap, so one flap is going, the inverting, once you are inverting it, the lower, the below, the outer side of the flap is getting exposed over it. So that's why the connection and the adhesion becomes little more. So above the all technique, if you have a cabbage flap, that tends to have a little more stabilization of the flap. The most important is that If you have an inverted flap, that flap has to be stabilized over the macular hole that can close the hole.
Okay, thank you. Thank you so much, Dr. Biswas.
Dr. Bishwas, sir, we have asked you, we have made you the host. Can you just try and play your video if possible?
Yeah, I'm just trying to join the same link. I'm just trying to join with the same link what you have given.
In the interim period, when Dr. Biswas is trying to connect, there are a few newer techniques also which people have published. Something called as macular hydration. So, which I had a discussion, Dr. Divyansh, a few weeks back regarding a chronic large macular hole. And I don't know, Dr. Divyansh, do you practice it routinely? Do you have a video? If you can show it to us, it'd be great, wonderful for our viewers as well. Or you can tell us
So
what
currently I
exactly.
don't have a video, but yeah, so I have done in at least one or two cases where so I don't believe in stuffing the macular hole. So that's the reason why I had thought about this, that if I'm not thinking in that perspective that I don't want to stuff either an AMG or a free flap or a retinal graft or something like that. So why not to disengage? Because the cause, very important, is to look for whether the edges of the macular hole have got adhered to the RP. If the edges have got flat adhered to the RP, that means your further peeling is not going to help. So you need to release that adhesion from the RP or redetach the hole, so that you use a 42 gauge cannula. And there are different techniques. So we do not have the Alcon based system. So we use more mechanical systems using 1 cc syringe and connecting it to a 42 gauge cannula, and one of our assistant is injecting. And we need to create like 4 blebs, and the 4 blebs would cause the elevation of the whole macular hole. And because of that detachment, and the retina would become significantly free or loose. And then when it settles, once if you're doing such kind of a hydration of the macular hole, you should not do a complete fluid exchange. So it should be done around 90 to 95%, so that the fluid is there, and that when it resettles, that would help to close the hole or decrease the size of hole. So I would say I had tried in at least 2 cases of that. One, it had worked very well. Another one, it did not. I expect that because probably the detachment was not enough. So you need to detach at least around 3 to 4 disc diameters around the macula. So, and 4 different areas of injection sites, and the edge means the macular hole edge should get detached. Then it works well. So we can have a discussion whether anybody else can also have experience in foveal hydration. I do not have the video currently, but with me.
Yeah, actually, I was just trying to search on the internet because it came in my feed a few days back. I don't know if I saved it or not. Anyone has any experience? Yes, Dr. Mohit.
Yeah, so this was actually there was a acronym, I think it was published in Retina just, I think, either side of COVID. I think this was just post-COVID, in which they actually tried to do this. That's not the first time this was done, but that's the first series that they had. And then so there are two issues with this, and and that's why I don't do this. I know a colleague of mine who's actually done this in one patient, and we had a class, and I remember being the devil's advocate. And I'll tell you one thing. So if the edges are flat, and please, everyone's happy to shine some light on this because I don't have an answer. So we are essentially operating type 2 closure holes. So we are beginning our hypothesis by saying that we do not believe in type 2 closure. And anything which has had a type 2 closure or is like that, or let's say it's been a traumatic hole, been lying around for 10 years, and absolutely is like that, we're going to try and operate them. Now, if that has to be the first caveat, then okay, fair enough. The second thing with that is, then we are also trying to look at, irrespective of hole size, we want to do a partial fluid exchange, because if we let that fluid wave pass all through, it'll actually come out through the, because I use this technique for two things. If you get a retinal fold, that's what you do. You inject subretinal fluid and you form a bulla, and that's what causes and then the rest of the steps are similar. Or if you were to do retinal translocation as was done previously, the difference there and here is there is no hole, so that fluid wave will not pass through. If it's a large hole and we're able to mechanically open those type 2 closed stuck edges, and if the fluid wave is large enough, it will actually come through the hole and that bulla will actually go away. So to my mind, those are the two issues with this technique. That it sounds great, but it begins with the concept that type 2 closure is no closure. And irrespective of chronicity, anything which is stuck, we will want to try and operate that also. So those are my two major issues with that technique. And I just wanted to add one thing if we have time. We actually published a couple of papers on autologous retinal transplant, one of which was with Dr. Dhanashri and Dr. Rupak Kanti. And we actually looked, this was 2022 IGO, when we looked at 3 techniques of harvesting the autologous retinal transplant. So we looked at, it was 3 centers. So you could use scissors to harvest the graft. You could use the punch that Dr. Rupak Kanti Bishwas sir does, or you could use cutter along with the finesse loop to try and get it out. So it was a small series, but it was 3 page. So if the retina was detached to begin with, scissors were superior to both the trephine and finesse loop / cutter. But if it was an attached retina, like the case that Shishir showed, then the retinal trephine / the finesse loop were superior to the scissors. What we got. And we also showed if you have the MIOCT, I think that can be used intraoperatively to adequately size your graft. I don't think MIOCT is a great tool, but if you have it, then that might be a very, very, very small niche use case for that particular patient.
Yeah. So I think in the interest of time, Dr. Biswas, what I will recommend is that if you could record your talk and share it to us, we will be happy to share it on our Insta page and circulate to all our viewers so that they learn from it. And before we close, I would like all the panelists to. Okay, Dr. Biswas has tried to share.
Is it? Yeah, it is now. Just I'll show this.
Sure.
Is
Yeah.
visible now?
Refine. Yes. Yes, we can see it. Yes. So
yeah, I'll just this is the trephine. I'm just showing it. It's an arbitrary size of 550 micron. So we'll go to the next video. Yeah. So this is you can see, you can choose a location of the predetermined size of your trephine. And this is what exactly almost the real-time video what you are seeing. So by the crushing effect, you can, and with the left hand, this has to be done under saline. And then with the left hand, you just gently pick it up. There may be a few tags can be attached, so which you can cut it up with the scissor, and then do the fluid air exchange. Don't change your hand. So even if it is a crumpled over your forceps also, it just once you are trying to place it there, it will automatically unfold due to the small amount of the fluid which is remaining there. And I'm just gently tucking the margins so that it does not go beyond that area. So it remains into that area, and then the fluid air exchange you do it. This is as simple as that. Only thing is that you need to have a little bit 15 to 20% of the larger size, because you need to consider the graft shrinkage so that it remains into the same area.
I was
and
still,
this is how is this is the pre-operative and the post-operative outcome. Yes, you can see the graft area is having some amount of the almost similar kind of a retinal architecture in that area, though some amount of the photoreceptor changes, you can see it here, but it has a significant amount of the similarity with the retinal tissue. And if you see, this is, I will show you the, this is the normal multifocal ERG. And this is a case of multifocal ERG where our standard ILM peeling has been done for a closed macular hole. This is where a free flap has been put it there. And this is the graft area where you can see a significant amount of the macular. In one page, if you see, this is the normal one, this is the classic peeling, this is repeeling and plugging, and this is the graft area. Though there are some areas of depression surrounding that area, probably this is because of the previous surgery, trauma to the previous surgery itself has caused. But again, it has come back to the central area is having the peak is there. And if I don't have the multifocal ERG, but I did central 10-2 of the same patient. And if you notice very carefully, the central area is showing 25 to 27, 26 kind of decibel of the central area of those, the patient data. So this is the indirect evidence that this retinal graft, it works. But again, we need to go a long way to prove that it is having a significant amount of the functional ability.
Okay. Dr. Biswas, still I will request you if you could just record a short 5 to 7 minute video presentation of this technique and your thoughts on this advanced macular hole closures. That will be really helpful for us and for all the viewers as well. And before we close, one quick question to all the panelists. If we divide it as macular holes less than 600 microns, 600 to say 1500 microns and over 1500 microns, your go-to technique for each one of this classification. We'll start with Chitranjan, then Sharat, Mohit, Divyansh, Avnish, and Shishir.
So less than 600 traditional ILM peeling, then 600 to 1500 you put a large one. So there will be ILM flap, cabbage kind of ILM flap, and if it is 800,000 kind of thing, I'll go with Chintan PFCL assisted, not to lose it. And more than 1500 probably Rupak sir's Trifines will help for retinal tissue transplantation, or if amniotic membrane is available. Better is retinal transplantation. Rupak sir, I have seen your video previously also. I did not comment, but I have seen your videos previously. Thanks.
Yeah, I know most of you have already seen it because I'm
Yes, sir.
showing it for quite a long time. You
Yeah.
can all try it out. This is not a very difficult technique. You all are very experienced surgeon, and
Yes.
people have started using. I will share with you individually. In fact, Shane Matthew of he was sharing it. Almost he did significant number of cases with this, and he got a
Yeah.
good result.
Yeah, correct.
Yeah, Sharat.
Yeah, personally, I want if it is less than 400, I usually do a traditional ILM peel without any putting anything. If it is more than 600 to 1200, I do a ILM peel, inverse ILM peel. And more than even up to, I usually won't like to put any agent in the first surgery. If I'm doing a second surgery, I go with a ILM graft from elsewhere and I put it. But I won't put AMG or graft it.
Okay. Shishir, your thoughts on larger macular holes?
Yeah, so primary surgery always a ILM flap. If it's a larger hole, probably I'll put like Dr. Chintan's technique, put a PFCL and then do a larger temporal flap. Mobilize more of the ILM from the periphery and put a larger temporal flap. But if it's a resurgery where the hole has filled, then I'll go for an autograft.
Dr. Mohit?
Up to 600 microns, conventional ILM peel gas face down. 600 to 1100, 1200, I'll do I'll do a multi-layered ILM flap. I will not operate anything above 1200 except under two conditions. Only eye with retinal detachment, or if it's a myope and has a large hole of any size, because I know that that is the cause for and can be a cause for other things. Otherwise, I am not operating anything over 1200. I am yet to be convinced by anybody, and I say that with all humility and hands folded, that a 1200 micron hole that you close otherwise gets vision back.
I anticipate that answer. That's why I'm asking
That I
individually.
agree. It won't get vision.
Not operating anything, and that's pushing it. I might not operate over 1000, but maybe definitely not over 1200. I might not operate idiopathic or a first time hole over 1000. मेरे तरफ से ये है.
No, the thing is, even after you operate, he's still going to use the better eye for all his routine work and things like that. So there's no
I'm
point
just
of.
not convinced that it does anything for anybody except our egos and maybe the OCT technicians, and maybe the mental health of that patient by saying that the OCT is now continuous and that's it.
Okay, Avnish and then finally Divyansh.
Okay, so from my side, I think I still will go with 400 microns for conventional. More than 400, I would do the ILM peeling, and I can switch from visco-assisted to PFCL. For me, I think in the practice where I am, I would want the hole should also anatomically should show as with all due respect to Dr. Mohit, I would want my patients to be, like happy there's a hole closure. Second thing which I wanted to emphasize is there are a lot of meta-analysis which have lately been, published, 25, 26, which are showing better results with inverted flaps, AMGs and ARTs. I think maybe in the next few years, we'll have actually some concrete data as to even with my very big larger holes, the visual acuity increases. And one more thing which I wanted to emphasize was whether I was doing it under fluid or, like putting the visco. I've tried doing it under FAX, but it becomes very difficult at times and you may actually damage the retina more. So I try to put more visco, but I think if you can see my OCTs, they are favorably well, and the patient does. I have not mentioned the I think the visual acuity, but I'll get back to that also. So for me, it will be if it is more than 400 microns, I would do an inverted flap cabbage technique. Can use visco assisted or PFCL depending what I have in my hands, and AMG or ART because I feel that causing a puncture or maybe sometimes can cause detachment, and AMG is still a safer bet. You just need to tuck it, and the results are favorably okay as compared to what the studies are showing. So concretely, I have a couple of patients which are like 6 months to a year's time. So I would be more than, like you'll be in a better position to talk about it maybe in say 5 years of time from now as to what the AMD results are. Yeah.
Yeah, Dr. Divyansh.
So Bhavik, one question to you itself. What are you suggesting as whether it is the minimum diameter, the maximum diameter? What is the size of the hole which you suggest as?
The
Is it the
maximum,
minimum diameter or the maximum?
the maximum diameter, maximum diameter.
So the problem is the maximum diameter can be as wider, but the problem is they can have a high kind of
Yeah.
roof also. So for me, I would consider the minimum diameter for all the numbers which are suggested. And for the minimum less than 400 to 600, I'm talking about the minimum
Yeah,
diameter,
minimum diameter. Yeah.
where the height of the foveal hole is there. So the maximum can be anything, it doesn't matter. One thing which I find out is if you divide the maximum means the outer diameter versus the minimum, and if you have a ratio of 0.5 and anything which is lesser than 0.5, that means when the flaps would close, it may not completely cover each other. So that would be the time I would think of inverse peel. Any other adjuvant, I am not sure. I do not want. Mohit has already contradicted me for the foveal hydration. That was one of the rare cases. But yeah, I really do not want to close all holes. If it's not closed, I would tell with folded hands, that's maximum I can do. And I don't want to shove anything inside. Thank you.
Wonderful, wonderful. So, thank you so much, Dr. Chintan, Dr. Vidhi, and especially Dr. Rupak for joining in and giving us your fantastic inputs, and Dr. Chintan for his wonderful study. If it's not published, I would encourage you to please publish your data. That will help us to understand the technique better. Not just us, I mean to say, viewers, retina surgeons across the country, and to all our panelists for their wonderful inputs. We'll meet again shortly with a different technique. I think macular hole is done and dusted now. We'll come with something else.
Bhavik, sorry, I'm going to butt in before that, man. What's your take on this, man? What's your go-to thing with this? You have to give your
I think
opinion.
he has done three sessions of moderation. He would be the best person to
No,
talk about.
to be honest, because of this moderation, my knowledge has increased so much. Now, problem is that I'm a little confused when it comes between 600,000. So I call up different people and ask them, and then decide what I want to do based on the patient's OCT. And as Dr. Divyansh mentioned about the minimum linear diameter as well. So yes, I agree. Less than 400, even 600 as well. Conventional ILM peeling. Above 400, above 600 will go towards the flap. And I'm still a little conservative towards using an adjuvant. A PFCL is the one which I would go to, as Dr. Chintan mentioned, for larger macular holes. So with this, we come to an end of the session. Thank you all. It was a fantastic session, and we'll meet again, and we'll update you the time and the date for the next session, next topic as well. On our YouTube and Instagram channel, you're free to send us give us suggestions for next topic that you are interested in learning. That will help us to devise a plan towards our next further sessions as well. Thank you so much to all our viewers and listeners.